اني سكرين الشير كده مال دیدم میتونیم بخاطر که ده پی دی
بله
اف چی
بالکل سه استاد
میتونیم که شروع کنیم ببخشید. So today our lecture will be about pericardial diseases and management, and the content of the lecture. So how we're gonna divide the diseases and how we're gonna talk about it. We will start with very superficial anatomy, basic anatomy. ده القدر ده عمقش نمیریم، بسیار سطحی اناتومی بسته قلبانی فقط از pericardial سکه میبینیم و درباره فیسیولوژی و پاتوفیسیولوژیش گپ میزنیم یک کمه و درباره سببش هم همچنان و چی رقم میتونیم که تشخیص کنیم یک مرض با یک مرض دیگه بخاطر از که pericardial disease که از یک دانه بلکه چندین دانه است و امی رقم درباره منیجمنت و دیاگنوستیسش هم گپ میزنیم. So we're starting with the anatomy of pericardial sac. We have two layers, and we have a fibrous layer and we have a serous layer. Serous layer is more visceral to the heart, while fibrous layer is actually the most superficial one. So the fibrous layer is the one that actually connects the heart and the sac to the diaphragm at the central tendon. And we have some ligaments as well that connects this fibrous sac to a sternum, so it can support it like anteriorly. And so about that was about fibrous pericardium. So if you start from going from the most superficial part to the deep part, then our superficial layer will be fibrous pericardium, and the deep layer would be our serous pericardium. And this serous pericardium is divided into two other layers, that is parietal and visceral. So if we have a scalpel and we cut through this fibrous pericardium, then we have our parietal pericardium, and if we cut another section through it, then we're gonna get our visceral layer of serous pericardium. And we have as I mentioned before, we have a parietal layer and a visceral layer. And if we have the visceral layer with adipose tissue, then we call this epicardial. So usually what happens that in most of the textbooks, when they say visceral layer, they actually mean epicardium. So between visceral layer of pericardium and parietal layer of pericardium, there is a cavity, and that cavity is actually filled with fluid. So that fluid might be around 50 milliliters, and it is secreted by cells of mesothelium, and it lubricates the membrane that lines the pericardial cavity. So the function of this fluid is that it protects and cushions the heart. That's one function. And then another function is that it prevents heart overfilling, and it prevents friction. So we can have a very frictionless or friction limited movement within the layers. So it is so the fluid in the cavity is designed to allow the two layers during contraction and relaxation. So it allows for much more of a comfortable gliding movement. That is another picture as a coronal section of what I just talked about in the previous pictures. So as you guys can see, endocardium, the innermost, and then we have myocardium, and then the visceral layer that is actually viscera. It is to our viscera. So in this case, heart, near to the heart, and then we will have pericardial, a space which is between the visceral pericardium and parietal pericardium, parietal serous layer, and then we have the parietal outermost fibrous layer. So now we will talk about pericardial diseases. When it comes to etiology of pericardial diseases, there's a very important point that you guys should never forget, that mostly or mainly all of the causes are they are idiopathic. But when we talk about idiopathic causes, we should always be suspicious that we have an infectious cause the farthest. So it can be that it is idiopathic, but at the same time we have these infectious causes that are most commonly caused for pericardial diseases. Just put this down in here. So it can be, as I said, infectious causes, and this can be bacterial or viral, and it can be fungal and parasitic. So when it comes to infection, I will discuss which one are most relevant, and that also depends on which diseases we are talking about. So, for example, for tuberculosis, it will be constrictive pericarditis that will be most relevant or most causative factor. And then we have trauma that can be due to the direct or indirect trauma and surgery. If we have a patient with open chest surgery, then they are more prone to have these bacterial infections, obviously. And that we have neoplasm, which is different kinds of cancers. Might be, I will talk more about that too. So it can be a breast cancer, lung cancer, renal cell carcinoma, and we can have metabolic immunologic complications as well. So other vascular disorders might be uremia, rheumatoid arthritis, systematic lupus erythematosus, and pre-arthritis nodosa. So these are just a general causes that might be. So it is just a overview of what can be the underlying problem, and these problems will later on appear as pericardial diseases. So due to the injury from these diverse causes, as I mentioned before, we have the pericardial response, and this may include our pericarditis, constrictive pericarditis, pericardial effusion, and cardiac tamponade. So these are the diseases that we're going to talk about, and I'm going to make sure that you guys know about the physical examination, the clinical findings, and as well as management. So pericarditis, it is, as the name is referring to, is inflammation of the pericardium, and then the constrictive pericarditis will be more of the chronic situation where we have recurrent or chronic pericarditis. And then we will talk about pericardial effusion, actually kind of not separately, but with pericarditis, because if we have pericarditis, then we have a much more likelihood of that progressing to pericardial effusion. And last but not least, we're going to talk about cardiac tamponade. So starting with pericarditis, as I mentioned before, we have two types, acute and chronic. Acute is if we have had pericarditis for less than 3 months, and chronic will be equal or more than 3 months. And the most commonly affected layers will be, in this case, visceral layer of serous pericardium, and parietal layer of serous pericardium. So if we have these two layers involved, then obviously our pericardium cavity is also being affected. And causes for pericarditis, as I mentioned before, most of the time the causes are idiopathic. So this is very important to remember, that these causes, like for the most time being, or whenever you're gonna get a patient, it's like idiopathic. But you should never forget that when we say idiopathic, you should always be suspicious of infectious causes. And these infectious causes, the most common one will be viral, and the least common one will be bacterial. So the most common virals will be Coxsackie B virus, and the very recent one that we had, SARS-CoV-2, and the least one that might be an infectious, but it will be bacterial, and that we Streptococcus aureus and Streptococcus pneumonia, as well as Mycobacterium tuberculosis. But don't forget that Mycobacterium tuberculosis will come later on, and that will be the most common cause for our constrictive pericarditis, the chronic one. And then another cause will be neoplasia, which is, we have a primary cancer somewhere else, and these lesions, these metastatic lesions, will infiltrate, and it will metastasis to the pericardium, and this can be due to the lung cancer, lymphoma, renal cell carcinoma, and breast cancer. Other causes might be from autoimmune origin, and it is antibody mediated, where antibodies can go and travel to our pericardium, and that would be rheumatoid arthritis, as well as systematic lupus erythematosus. So another cause will be uremia, and this is with patients with chronic kidney disease. And when we say chronic kidney disease, we actually mean like end-stage renal disease, where the patient is actually in hemodialysis. Uremia can be due to acute kidney injury, and in this case, we have excretion of urea and creatinine that fails completely. And then we have radiation, which kind of goes hand in hand with neoplasia. So if we have someone with cancer, then obviously the radiation therapy will come in contact with this, and then the patient is being more prone to actually to have a destruction of pericardial tissue due to radiation. And another cause can be patients who had myocardial infarction, and if you develop pericarditis post to 1 or 3 days, 3 days post to myocardial infarction, then we have post-infarct pericarditis. And if that develops between 14 days to months after myocardial infarction, then we have Dressler syndrome, which I will not go so in depth to. So coming to clinical manifestation of pericarditis and pericardial effusion. So just to mention about the pericardial effusion, what is happening actually when we have an inflammation in pericardium, then we have a lot of cytokines that are released, because when we have inflammation, then the process is that we have a lot of cytokines, and the cytokines will cause the blood vessels to become more permeable, which becomes and when they become more permeable, they kind of open up these capillaries, and the fluid leaks out from these areas, and it leads to the accumulation of fluid within the cavity, and it increases obviously the fluid, and there will be a increase in volume as well, which will lead to an increase in the size and will cause the pericardial effusion. So we can say that usually pericarditis can progress to pericardial effusion, but you can have pericarditis without having pericardial effusion. So the clinical manifestations of pericarditis and pericardial effusion, which will be the same, we have a very particular spatial type of chest pain, which can be positional and pleuritic. So this chest pain, the type is sharp. We have a very sharp chest pain in comparison to angina, and the location will be substernal. So it radiates to trapezius, and the pain is known to be positional, meaning that the pain increases when you're in supine position, and it decreases when you're standing up or leaning forward. So that will be for the positional part. And when it comes to pleuritic part, we mean actually the respiratory cycle. So what happens when we are inhaling during inspiration and expiration. So the pain will increase during inspiration and will decrease when we're exhaling. Some physical findings in the pericarditis and pericardial effusion. For the pericarditis, it will be the pericardial friction rub. It is a multiphasic heart type sound. So it will happen during multiple phases as atrial systole, ventricular diastole, and ventricular systole. And for the pericardial effusion, we have our S1 and S2 sound will be very distant, muffled, or decreased in a sense. And then we have dullness to percussion as well if you're palpating the left lung base. And also a bronchial breathe sound we have, since if we have an effusion, that means that our pericardium has actually expanded, and then it is affecting our lung in a sense that the air will not be moving all the way to alveoli. So the air will stop somewhere between the bronchial, and that is what will cause this bronchial breath sound. And tactile fremitus, which the picture indicates, you just make the patient to say a repeated phase like 99, and then you will start your percussion and see if there are any abnormalities. So talking about diagnosis of pericarditis and pericardial effusion, we can use a 12-lead ECG when it comes to acute pericarditis, and this will show you a ST elevation. It will be diffuse, it will be concave, and I have a picture that I will be showing about this ST elevation, and it will be mainly in pericardial leads, also in inferior and lateral chest leads. So there will be changes in PR segments. It will be depressed and primarily involving inferior leads, and we will have a low QRS voltage. And this is patients with large pericardial effusion. This will be more helping if we have patients with pericardial effusion, and then see it will be more significant in that case. And then we have cardiac imaging. It's supposed to say cardiac imaging. We have chest X-ray, which is not optimal in this case, but it will help us to kind of rule out a lot of other things, such as like tuberculosis and other diseases that might be or other complications that we think are missing, that it will be. So we can have echo, it shows effusion, so it's a good one, and then CT and MRI will show us some changes in the soft tissue. And just a summary to if you get a patient and if you are suspecting some pericarditis, then the general criteria actually goes like, you look for the chest pain specific to pericarditis, the one that we mentioned before. It is positional, it's pleuritic, and then when you're doing auscultation, if there's a friction rub and during ECG changes, we have this diffuse ST elevation, it's concave, and PR segment depression. And another thing that will be also very good to know, that if the effusion is new, or if it's worsening, or if it's reoccurrent. So another thing we can do for diagnosis, we can have pericardial fluid analysis, where we get some fluid out of the pericardium, and in case we see if it's a plurant, if the patient has increased fever, or the patient is septic, and in case of malignancy as well. So these tests, you can send them for cultures, gram stain, which will indicate bacteria, and fast acid bacillus, which will rule out the tuberculosis, and cytology, which will be like in case of malignancy, and if we see if there's any type of cancer around the area. So this is about the ST elevation and the PR segment depression that we talked about. So it's a normal reading. You will look at the isoelectronic point, and you see if there is a depression or elevation. So about the treatment and management, since we said it's pericarditis, we have inflammation. So high doses of non-steroidal anti-inflammatory drugs will be very helpful in this case. So we will have probably ibuprofen or indomethacin. Aspirin is actually commonly used. Another type that actually they might be including aspirin, and sometimes you see to just get more result, they will include colchicine, and this will be helpful to reduce reoccurrence of pericarditis. We can also use steroids, but it is not actually very optimal, except if you have patients with autoimmune diseases or patients with tuberculosis, because steroids, they tend to kind of increase this reoccurrence rate that we will have pericarditis more. So yeah, patients with uremia and autoimmune diseases such as rheumatoid arthritis, it is good to kind of not treat, but to get in control of their flare up first, their autoimmune diseases that they have, so that the moment that is under control, then you can start treating them for the inflammation. So steroids will be good in this case. I think someone has raised their hand.
استاد بخشش باشه من در قسمت تریتمنتش ما گفته بودیم در ام آی باید دواهای نان استروید انتی انفلاماتوری درگ مزاد استدباب است. باز امی قسمت پریکاردایت که از سبب پست ام آی با وجود ما انسرت بیتیم یا نه؟
که دو قسم ایره فقط گفتن که دو وقت میتین، وقتی که بخاطر که گفته استروید باید تا که میتونین آدم باید نتا بخاطر از اینکه اگر ضروری نیست، یا فقط وقتی که مثلا اگر مریض دارین و اوتویمون دیسیز داره، مثلا روماتوید آرترایتس داره، یا
نه استاد منظور من نان استروید است، یعنی ایبوپروفین، اندومتاسین.
اینا رو زیادتر ما وقتی که خواندم گفتن اولین یوزی که میکنن اینا به خاطر انفلامیشن میتونن که از می استفاده کنن به پریکاردایتس، و اینا میتونن که گت کنن امرای کالچیسن که یکمک افکت زیادتر بده.
اما با دکتر سیدزهرا ما با دکتر سید میگم که بله بعد از انفلامیشن که چی مای پریکاردایتس با وجود می با اون کیس آلریدی اسپرین استفاده میشه، با اون کیس اینسایدرز میتونیم که استفاده کنیم.
درست است.
دکتر وحید ببخشین پس تکرار کنین، صدایتان صحیح نامه.
ما گفتم برش که در اینجا کیس اگر پست مای پریکاردایتس با وجود بیاید، در اون کیس آلریدی اینساید استفاده میشه که او اسپرین.
بله.
اون کمک میکنه که در پریکاردایتس در تریتمنتش چی کنه استفاده کنه.
اوکی.
دکتر سیدزهرا دوام بده.
خب درباره استرویدز که گپ زدیم و امو زیادتر که یوز میکنن این پردسونن است و متل پردسونن است، و بعضی انویسیو تریتمنت که است که زیادتر کمک چی میگن جدی تر است، و ایده وقت است که مثلا اگه کدام مریض داشتیم که سرجری داشت، یا که وقتی که سرجری داشته باشن زیادتر امکاناتش هست که مثلا پوست اپراتیو کامپلیکیشنز باشه، در اون صورت میتونیم که پریکاردیو سنتزیس استفاده کنیم که فقط میتونیم که بسته هر چقدر فلویدی که در بین پریکاردیوم هست و امور بکشیم. و از پریکاردایتس خلاص شدیم، حالا درباره کانسترکتیو پریکاردایتس گپ میزنیم که اکیوتش هست، که اکیوت وقتی که اکیوت پریکاردایتس داریم بعد از چند وقت بعد که گفتیم 3 ماه یا زیادتر از 3 ماه وقتی که تیر میشه رو میتونیم که بگوییم که کرونیک میشه، یا امکانات داره که پریکاردایتس ما یک دفعه نه چندین دفعه تکرار شده باشه، ریکارنت باشه. در اون صورت هم میتونیم کانسترکتیو پریکاردایتس داشته باشیم، و این چی میکنه که امی فایبروسیس که در پریکاردیوم هست همون زیاد میشه. در قسمی که در عکس میبینین من براتون میخوانم که چی نشته است اگه شاید کم دیده نتونین. The fibrotic pericardium encases the heart in a rigid shell. So what happens that we have like a very rigid, tough, fibrous and elastic shell which constricts the heart. And if we have this heart being constrict, then obviously we have a less ventricular filling going on, less cardiac output, and that will lead to a lot of more complications, which we're going to talk about. Common causes will be infectious causes. So any causes that was relevant to pericarditis will be relevant to constructive pericarditis. So just take those causes, and if they're recurrent more, or if they're more severe, then it will give us constructive pericarditis. But in case of infection, tuberculosis will be the most common one. And then, as we mentioned before, neoplasia, radiation, and autoimmune diseases. So clinical manifestation of constructive pericarditis, we will have heart failure-like symptoms, and that will be mainly our right heart, then our left heart side. So the symptoms that are very common for right heart failure will be jugular venous distension, and that is due to the increased pressure in superior vena cava. We have hepatomegaly, which will be due to pressure in inferior vena cava, and then ascites, that we will have accumulation of fluid and peritoneum and pedal edema. For the left, we will also have left heart side failure symptoms, but it will be least common, and that will be hypotension and pulmonary edema, specifically proximal, which will cause the proximal nocturnal dyspnea. So why we have it on the heart, on the right side and not the left side? Because as we all know about the anatomy, we have the left ventricle, which is thicker. So if we have a constricted heart, and if we have a lot of compression going on, then obviously our right side will be more prone to feel any changes than the left side, which is already thick. So yes, in this case, we will have these right heart failure symptoms, which will be the clinical manifestations. And in physical examinations, you will find Cosmal sign, which is again jugular distension, but when you're during inspiration, that will be. We have pericardial knock, which is during S1 sound and S2 sound. S1 is for our ventricular systole, and then S2 for ventricular diastole. So after that, we will have after S2 we will have a early mid diastolic heart sound, and then we will have pulses, paradoxes, which is actually not very important when it comes to constructive pericarditis, because you can only see it around 20 to 30% of patients, which does not actually indicate or give you a definite finding of constructive pericarditis. This will be pulses, paradoxes. We will talk about it more in cardiac tamponade, which will be actually a very good finding that one can use this and see that it can be cardiac tamponade. So this will be for the physical examinations. And diagnosis of constructive pericarditis, we will have echocardiogram. We will use that, and that will kind of show us the thickening of pericardium, and that is due to the fibrous layer being thickened. We have reciprophasic flow of the blood across the valve. So it is actually generally goes with it. When you have inspiration, you have this venous pressure, and then everything, when you have a huge venous pressure and it goes down, then obviously our tricuspid valve will be will have a massive inflow, and this can be seen in echocardiogram. Unfortunately, I could not attach any videos in here, but if you search for it in YouTube, you will probably they have very good videos where they show echocardium and this reciprophasic flow and how this might look. Then we have some septal bounce as well during inspiration, and we will have inferior vena cava that you can see kind of a dilation of that because of the hepatic vein flow during expiration. So these are the things that will be the findings, and a more accurate picture will be good if you search it on YouTube and see that how it actually looks in an echocardiogram. And then another way we can use is actually catheterization, where we put a catheter to measure the venous pressure, and the ventricular pressure curve can be like, we can have the jugular pressure where it shows it is something like a Y curve and it will show a very decreased Y curve, and it also can show us the ventricular pressure curve, and the findings will be, it is the same actually diagram, so it will be deep. We will have a deep we will have a deep point, and then we have a plateau point, and this will actually be that the right ventricular and diastolic pressure equals to left ventricular and diastolic pressure, which is actually, if in cardio in constructive cardiomyopathy, I think we will have a greater lift in diastolic pressure. So it's in this case, in constructive pericarditis, it will be equal. And CT and MRI will show us soft tissue changes. In this case, it will be thickened, and we have a thickened pericardium. Chest X-ray, if you use that, in lateral VU, you can find calcification, and that will be due to the fibrosis, increased fibrosis. And that is in case of our tuberculosis. And a 12-lead ECG will also show us a low QRS voltage. So when it comes to treatment for constructive pericarditis, so we will try to reduce their venous congestion as much as we can, as we mentioned before, that how the heart is constricting, and then we don't have a proper filling going on. And if we don't have a proper filling, then yes, our right atrium, right ventricle is, if we don't have if we cannot relax it during diastole, then we do not get enough blood inside the ventricle, and that blood it remains in the right atrium. Obviously, it has two ways to go, like right inferior vena cava, superior vena cava, and that is where we get our jugular distension, as we talked about, and about inferior vena cava as well. So the treatment for this will be to reduce their venous congestion and fluid restrict, and to restrict their fluid intake, or to put them in diuresis. And another thing, which is like the definitive treatment in this situation, will be pericardiectomy, which will look something like this in the picture, and it's in order to get rid of the tough pericardium, because there is not much we can do than having a surgical procedure going on. So last but not least, we're going to talk about cardiac tamponade. So to put it very simply, how to differentiate between cardiac tamponade and pericardial effusion is that pericardial effusion is much more gradually happening. So we have fluid accumulation throughout the time, a period of time, while in cardiac tamponade, it can be that increased amount of fluid, or we have a very rapid accumulation, rapid to the point where the heart cannot actually relax fully during the diastole phase, and it is compressing hard to the point where it cannot relax and cannot fill, and that will disturb our filling process. So cardiac tamponade will be increased amount of fluid in a very rapid time, and the pericardial effusion will be just gradually fluid accumulation. And clinical manifestation of cardiac tamponade, we have a big triad, and that is, it is actually a triangle for the most part. So what we have, that we have the jugular venous distension, as we said before, and this is because we have a prevention of the end-diastolic filling, as I mentioned before, which leads to the blood being backed up from the atrium and resulting in the venous distension. And we have muffled heart sounds because the heart is surrounded by fluid, and it is farther away from the surface of the thorax, so it makes it hard to hear those sharp and very good sounds of heart that we hear in normal cases. And hypotension, because obviously we have fluid in our pericardial sac, and the diastolic filling is disturbed, decreased cardiac output, and that will lead to our hypotension. And coming to plexus paradoxus is actually normally if we're gonna talk about this, so how this is put is that we have like between 5 to 8 millimeter mercuries in difference in systolic. But the problem is that when we have plexus paradoxus, we have during effusion, pericardial effusion, it will be very moderate. But if we have a cardiac tamponade, then the ventricular collapses, and the amount of blood that is coming, it will push our septum towards the left ventricle. And when that is pushed towards the left ventricle, then obviously we have less of endostaltic filling. So we don't have a lot of blood that can be pumped up back. And this will show us a more than 10 millimeter mercury. When it comes to systolic blood pressure, you will see a huge difference in there. So this will be for our plexus paradoxus. And obstructive shock is another manifestation, and that is just as straightforward as it can be. We have pericardial tamponade, we have obstruction. So we have, if we're going to think about it like this, we have arterial hypotension, and the patient is presenting with tachycardia, and then the signs of tissue of hyperfusion present, and then we have circulatory shock, which means that we have low estimated cardiac output or stroke volume, and we have high central venous pressure, and that will lead to obstructive circulatory shock. And this is so in cardiac tamponade, people will have this, but it is also for other diseases as well, such as it can be for the embolism, pulmonary embolism, I guess, and the pneumothorax as well. So yeah, in tamponade, you will see pericardial effusion, a small left and right ventricle because of the compression, and then there will be a dilated inferior vena cava. And the diagnosis for cardiac tamponade, we have ECG changes here as well. That will be a decrease in QRS voltage due to the fluid. So we have a lot of fluids, and then obviously the voltage is embedded, and we cannot have as high voltage as we expect or normally we have. We have electrical alternance, which means that we have this apex of the heart swinging, making it hard for the vector to detect those electrical impulses, and that's why we will have a lot of electrical alternance when we have cardiac tamponade. And when it comes to echocardiogram, we will have right atrium and right ventricle collapse during the stall, because yes, heart is compressed, it cannot relax. We have pleuritic inferior vena cava, which I discussed before, that it is due to the fact that we have a dilated inferior vena cava, just because that our atrium cannot get rid of the blood the way it's supposed to get, and we don't have enough space in the ventricle to take that blood. So we have a buildup of the blood in the atrium, and that will lead to blood going from where it actually came from. So inferior vena cava will be dilated, and respiratory phasic changes and blood flow across the valve, and that will be also the tricuspid valve, that during inspiration we have this venous pressure, and this will cause that we have a massive inflow of blood, and that will be seen in the tricuspid and mitral valve, but tricuspid because of the venous pressure. So treatment of cardiac tamponade will be that we try to treat the shock, obstructive shock that we have, and that's due to we can give IV fluids to increase preload and blood volume. We can give vasopressin to increase the stroke volume and heart rate, contractility, and then we can another way is to drain the pericardium. So as we mentioned before in the other diseases, that we can have pericardiocentesis, if it's an acute form, and then if we have recurrent of cardiac tamponade, then we can have a cardial window to help us with that. And then for the intrathoracic pressure should be kept low. So in the case of emergency, you just want to avoid any intubation to just keep that intrathoracic pressure as low as it can be. And that will be it for this lecture. I have included some sources and the book that I have used. And I think that is it. If there are any questions, then